afternoon all. We have a session regarding. So, am I audible?
I think some network issues, ma'am.
Okay. Okay, I think now it is okay.
Yeah, it's fine.
Yes. Okay. So, I will share my slide. Is it visible?
Yes, ma'am.
Yes. Okay. So, then we can start. So, today we are dealing, that is gastrointestinal symptoms. There are main three topics, that is nausea and vomiting, constipation, and malignant bowel obstruction. So, common GI symptoms we come across while we are dealing with palliative care patients, that is oral thrush, stomatitis, dry mouth, nausea and vomiting, constipation, diarrhea, and intestinal obstruction. So among these, nausea and vomiting, it is a very common and distressing symptom to patients and caregivers and also as a healthcare professional because it is very distressing to the patient and caregivers. So, how this nausea or no vomiting is prevalent? So, in advanced cancer, 6 to 68% of the patients have symptoms of nausea and vomiting. The 43 to 49% of the AIDS patient has nausea and vomiting. 70 to 48% of heart disease patients and 30 to 43% of renal disease patients also presenting you with nausea and vomiting. So, what is emesis? It is a biological defense mechanism to remove toxic or harmful substance from the body after ingestion. So, what is nausea? By the definition, it is an unpleasant subjective sensation and with a feeling of need to vomit. And it is associated with some autonomic symptoms like pallor, sweating, salivation, and tachycardia. So, this is just prior to the vomiting, the patient has an unpleasant sensation, that is nausea. Here, there is no expulsion of contents. Next term is retching. It is a rhythmic spasmodic contractions of diaphragm and abdominal muscles and which facilitate the regurgitation of contents into the esophagus. So here there is only the contraction of the diaphragm and abdominal muscles and the contents will be regurgitated into the esophagus. Here also there is no expulsion of contents. Next, the term is vomiting. The vomiting, here the expulsion of gastric contents is happening. And it is by the forceful and sustained contraction of abdominal muscles and diaphragm. This is the difference between nausea, retching, and vomiting. What are the objectives? That is, our main objective is to stop or reduce the frequency of symptoms and to establish a compliance of treatment. That is, most of the time the patient has persistent vomiting and they are not able to take oral medicines. So their compliance to the treatment will be decreased and they are not able to take oral medications and because of these continuous symptoms, that is nausea and vomiting, it will hinder the quality of life of the patient. So, by giving a proper or adequate treatment to the patients, we can reduce. So, what are the different types of vomiting? So, there are different types of vomiting which are presented in patients while they are receiving chemotherapy. The first thing is acute vomiting. Acute vomiting means it is occurring within few minutes to hours and it is resolving in 24 hours. So that is acute. That is, if the patient has symptoms of nausea vomiting while she is receiving this chemotherapy. Next is delayed vomiting. Delayed means it is occurring usually after 24 hours of chemo and it will be worst from 48 to 72 hours following a chemo and it can be last for 6 to 7 days. So occurring after 24 hours. That is most of the time the patient has nausea and vomiting the next day of chemotherapy and it will be worst from 48 to 72 hours. Most of the time it will last for 6 to 7 days. That's why most of the oncologists they will give, that is, antiemetics after the chemotherapy to prevent this delayed vomiting. Next is breakthrough vomiting. Breakthrough vomiting, here there is, it is occurring despite of antiemetic treatment. That is, patient has this intermittent episodes when when the patient is on antiemetics. Next is refractory. That is, it is unmanageable with current antiemetic regimen. Am I audible?
Yes, ma'am.
Yes, okay. So that is refractory means it is unmanageable with current. That is, it is not responding to any antiemetics. Next is anticipatory. Anticipatory, that is a conditioned response just prior to the chemotherapy. That is, the patient has the thoughts of or the memories of past chemotherapy, and this thoughts or and memories will result in a feeling of nausea and vomiting just prior to the chemotherapy. So that is anticipatory. So these are the different types. So how will it affect? So it will affect the patient's daily functioning, and it will hinders the quality of life of the patient, and non-compliance to the treatment, inadequate symptom control, that is fear, anxiety, poor absorption of medicines, and it will escalate the distress of both patient and family members. And next, how this vomiting is happening. That is act of vomiting. So the main high centers which are involved in vomiting is hypothalamus, cerebellum, labyrinth, and area prostrema. So there are different areas. That is, when the vomiting center get signals from these higher centers, it will send signals to the soft palate. That is first thing. Next is there is closure of glottis. Next, there is relaxation of the lower esophageal sphincter. Then the respiration will stop and the abdominal pressure will increase, and there is an anti-peristalsis movement is happening with contraction of the diaphragm and abdominal muscles, and the stomach will squeezes the contents out through the warmth. That is the act of vomiting. So, this is an active process, not a passive process. So that's why the patient is in the patient need some actions, that is need also need activation of the higher centers, and which send signals to the vomiting center and result in vomiting. So these are the four different four uh, key players for the act of vomiting. That is GIT, cortex, CTZ, that is chemoreceptor trigger zone, and vestibular apparatus. So these are the five players. That is, the next thing is vomiting center. So when these four areas will send signals to the vomiting center, and that will result in vomiting. So this vomiting center, this is located in the medulla, and this area prostrema is there, and that is send signals from the GIT and cerebral cortex and vestibular nucleus. So there are so many receptors which are involved in this act of vomiting. That is, first thing is dopamine 2 receptors, serotonin, there is 5-HT3 receptors, acetylcholine receptors, histamine receptors, GABA receptors, and mechanoreceptors. So these are the different receptors which are involved in vomiting. So in our normal practices, usually for all types of vomiting, usually we are giving a single antiemetic. So after this class, you have to study what are the different mechanisms of each type of vomiting, what are the receptors which are involved in each pathway, what are the antagonists we can give for each type. So otherwise, we cannot achieve a good symptom control for the patient. So these are the four different areas. That is, first is gut, next is chemoreceptor trigger zone, cerebral cortex, and vestibular nucleus. So from the gut, there are so many receptors. That is H1, that is histamine receptors, acetylcholine receptors, and serotonin receptors. So most of the time, the serotonin receptors are the main players. Next is chemoreceptor, that is D2 receptor, that is dopamine receptors, alpha 2 receptors, 5-HT3 receptors. So, what are the stimulants to activate these receptors in the GIT? So, the first thing is intestinal obstruction, then gastric irritants, cytotoxics, and radiotherapy. So, these are the stimulants which can activate these receptors in the GIT. So, morphine, digoxin, hypercalcemia, and uremia. These are the stimulants which can stimulate the receptors in the CTZ. Next is cerebral cortex. So, the main receptors are GABA, mechanoreceptors. So, these two receptors are activated by fear, anxiety, and raised intracranial pressure. Next is vestibular nucleus. That is acetylcholine and histamine receptors are the main receptors, which is activated by the movement disorders or vertigo. That is related with vestibular nucleus. So when these centers are activated, which send signals to the vomiting center. That is, in vomiting center, we have so many receptors. That is H1, acetylcholine, 5-HT2. So these receptors are activated and it will act on the upper GI, diaphragm, and abdominal muscles, and that will result in vomiting. So this is the main. So I think my screen is okay. Is it visible, my screen?
Yes, ma'am.
Yes, ma'am.
Yes?
Yes, ma'am.
Yes, okay. So these are the different receptors and different areas, and what are the different stimulants. So, something.
Hello, ma'am.
Yes, yes, there is some technical glitches there. Wait.
Okay, okay.
So I'm just stop the share here and I'll just restart it. Okay.
Okay, ma'am.
Is it visible now?
Yes, ma'am.
Yes, okay. So these are the different receptors and these are the different stimulants. So next, we are identify what are the uh, to block the receptors at various sites. So that is the important management. So what are the different causes of nausea and vomiting? So from the different causes of nausea and vomiting, so first thing is it is a chemically induced nausea. So chemically induced nausea means it is included, that is drugs, that is opioids, antibiotics, cytotoxics, and toxins like food poisoning, ischemic bowel, gut obstructions, metabolic organ failures. Next is gastric stasis, that is anticholinergic drugs, opioids, peptic ulcer, and that peptic ulcer gastritis could be due to stress, drugs, and radiotherapy. Next is stretch or distortion of the GIT tract, that is due to constipation, intestinal obstruction, mesenteric metastasis. Next is serosal irritations with liver metastasis and ureteric obstructions. Irritation of the GIT tract, that is with infection and drugs like NSAIDs. Raised intracranial pressures, that is, conditions which result in raised intracranial pressure include cerebral edema, space occupying lesions in the brain, intracranial bleeds, and infections. Next is movement associated, that is, vestibular disorders. Then anxiety induced, that is, anxiety and anticipatory vomiting. Next is environmental factors like food, smell, cleanliness, distaste. So these are the different types of causes for nausea and vomiting. So how we can investigate? How we can investigate the patients? That is, first you have to do the urine and electrolytes. Is whether any dyselectrolytemia is there or urine is there, and you have to check the serum calcium levels, liver function test, that is any altered liver enzymes, and any evidence of any infections. That's why we have to do a total count and differential count, urine culture, that is urinary tract infections also presenting as nausea and vomiting. So to rule out UTI, you have to do urine cultures, then abdominal X-ray or ultrasound to look for any structural causes. And we can do endoscopy, CT, MRI, that is for the interventions. In palliative care settings, if the patient has a good prognosis or good outcome, then we can proceed with the investigation. Otherwise, you have to think twice before doing any investigations in palliative care. Before, if it did not alter the line of management, we do not prefer any investigations. But if the patient has benefiting after doing this investigation, then we can proceed with these investigations and rule out the causes. So, what are the principles of management? That is, first thing is correct the correctables. That is, correct the cause. Any correctable cause is there, you have to correct it. Then we can consider some non-pharmacological measures, dietary modifications we can advise, and the next is pharmacological management. That is by block the receptors at various sites. So, what are the correctable causes? So, first, if evidence of constipation is there, you can give proper bowel management. And if opioids are the causes, then we can use a opioid rotation. And if any evidence of raised intracranial pressure, we can give steroids or radiations to reduce the peritumoral edemas. And if electrolyte imbalance is the cause, that is hyponatremia or hypercalcemia, then we can correct it and give proper hydration. That is, dehydration can also result in nausea and vomiting, so that we can give a hydrations. Any evidence of gastric irritation, we can give H2 blockers or proton pump inhibitors. If any evidence of infection is there, we have to start oral or IV antibiotics. And if hypercalcemia is there, we can provide hydrations and bisphosphonates. So these are the correctable factors. So what are the non-pharmacological measures? That is, you have to maintain a good oral hygiene and control the malodors. That is, especially patients with fungating tumors. That is, malignant tumors. With most of the time, that is head and neck. Patient has a fungating, foul-smelling ulcers or wounds. That time, this malodor can result in nausea and vomiting. Patients or ileostomy patients also has this malodors, and decubitus ulcer, that is bed sores, that also result in malodor. So this you have to control, and you can advise to use a suitable distractors and avoid situations which induce nausea and vomiting. And that is calm, reassuring environment, fresh air, and advise the patient to advise the caregivers to feed the patient in a proper position to prevent aspirations. And frequent small meals rather than advising a large boring meals, we can advise a small frequent meals and consume the food during the daytime, and advised to avoid fatty, sweet, and spicy foods and carbonated drinks, and eat the food which are easily digestible to the stomach. And these are the some dietary modifications we can advise as a non-pharmacological measures. What else? That is, keep the mouth clean and do oral care after each episodes of vomiting is also very important. And advise the patient to wear a loose fitting clothes have a fresh air with a fan or open windows, limit the sounds, sights, and smell that can induce nausea and vomiting, and give the contact information of the team. If patient has persistent nausea and vomiting, which is not controlled with the current medications, advise the caregiver or patient to contact the healthcare team. So these are the some methods usually we can practice in our routine practices. So next we are coming to the pharmacological management. So before going to the proper pharmacological management, you have to know how these what are the different antidotes which can block the giving an antiemetic. You have to identify what is the cause for this vomiting and identify the pathway which triggers the vomiting reflex. That is the what is which is the area involved in particular type of vomiting, and identify the neurotransmitter or receptors which are involved in that pathway, and choose a potent antagonist to the receptor identified, and choose the route of administration, whether it be oral, IV, or subcutaneous. So you have to identify the route of administrations, titrate the dose, monitor the patients for the symptom reliefs, and administer it at a regular or maybe start dose or maybe a 6 hourly dose. So regularly you have to administer the doses. So route of antiemetics as the patients, as per patient's conditions and preference, oral is the best and easiest way. But if the patient has severe vomiting, we can consider IV, subcutaneous, or subcutaneous infusion routes. Sometimes suppository, sublinguals, and transdermal patches. So routinely we are practicing IV, subcutaneous, and subcutaneous infusions. So, nausea and vomiting management guidelines in palliative care, which first thing is you have to document most likely causes. Most of the time, the patient has more than one causes. So, treat potential reversible causes and exacerbating factors like drugs, constipation, severe pain, infections, and coughs. And review the dose after 24 hours. If nausea and vomiting persist after 24 to 48 hours, you have to review the cause. So that most of that is 1/3 of the patient will need more than one antiemetic. The patient has more than one cause for the nausea and vomiting. So that time, if the patient is not responding to the current treatment for after 24 hours, you have to review the cause. If on parenteral, if we have started the injections or antiemetics as a parenteral route, considering to convert it to an oral after 72 hours of good control. That is also very important. So single antiemetic may not be adequate in most of that is more than 1/3 of the patients. So that time we can give a combinations. If the patient is presenting with raised intracranial pressure and uremia, we can give dexamethasone and haloperidol. So the combinations you have to use. So these are the some medications usually we are giving for antiemetic as an antiemetic. So first thing is metoclopramide. So metoclopramide is mainly a D2, that is dopamine receptor antagonist, and it is also in the higher doses of metoclopramide. It has an action of 5-HT. This serotonic action is also there. So it acts as a prokinetic agent, that is it will increases or induces the peristalsis, and it increases lower esophageal sphincter, and the usual dose is 10 milligram as fourth hourly to sixth hourly, maximum 100 milligram per day, given as an orally, IV, and subcutaneously. And it is mainly the indication is gastric stasis, opioid induced vomiting, and also chemotherapy induced. That is chemotherapy induced is mainly that is the high doses has a serotonic action. That is the mechanism. And the side effect is extrapyramidal side effect. You have to look for the extrapyramidal side effects. Next antiemetic, that is haloperidol. So haloperidol, it is also a dopamine. It is a D2, strong D2 receptor antagonist. And it is mainly for the opioid induced or metabolic causes. And 1.5 milligram to 3 milligram as a tedious dose we can give as per orally, subcutaneously, and IV. The maximum dose per day is 20 milligram. and the muscle rigidity can happen. Rarely, extrapyramidal side effects also are there. Next is 5-HT3 antagonist. That is Cetron's group of medicines. This is the one medicine usually we are prescribing routinely for all types of vomiting. So the indication for MSH or ondansetron is mainly for chemotherapy-induced vomiting or abdominal radiotherapy or intestinal obstructions. The normal dose is 4 to 8 milligram as an 8th-hourly dose. Orally, IV and subcutaneous preparations are available. So the you have to cautious or the side effects is headache, constipation, QT prolongation in high doses. So that is also you have to keep in mind. Next is hyoscine. Hyoscine, it is an acetylcholine receptor antagonist. It is cholinergic. And hyoscine butyl bromide is the medicine, and it is given as a 20 milligrams chat, 80 to 200 milligram per day as a subcutaneous and IV. And it is mainly for the intestinal obstructions, peritoneal metastasis. The side effects include dry mouth, tachycardia, and blurred vision. That is, it will reduce the secretions. That's why the patient has symptoms of dry mouth. Cyclizine. Cyclizine, it is an H1. One is an acetylcholine receptor. Promethazine. Promethazine, it is an H1, that is histamine receptor antagonist, mainly for sedations, and it is a painful injections. So it is an analgesic, 12.5 to 25 milligram as a slow IV or per orally. That is the promethazine, that is the brand name is Phenergan. So next is domperidone. That is, it is also DOP, but it has only the peripheral action, no central action. So it can act as a prokinetic agent and 30 to 80 milligram as a oral doses. So usually it is coming with along with that is Pandop D or Pandop DSR. So that is domperidone. Next is dexamethasone, that is steroid, and it is reduces the intracranial pressure and it reduces the peritumoral edema. So it reduces the permeability of the brain barrier to the chemicals. The high dose is 60 milligram as a daily dose, as a usually morning dose for 3 days, subsequently reducing to 40 to 6 milligram. That is, we can give as a trial as in higher doses for 3 days. If the patient is responding very well, we can slowly taper it down and stop. And usually we are preferring the steroids as an morning dose, that is before 3 p.m. Otherwise, it will result in insomnia. And along with the steroids, you have to give Pandop. Next is anxiety induced, that is GABA and mechanoreceptors, that is cerebral cortex is mainly involved. So benzodiazepines is the drug of choice. We can give lorazepam or clonazepam. That is mainly for anticipatory type of vomiting. So from the nutshell, that is, if drug induced, that is most of the time, that is opioid induced, the drug of choice is haloperidol or metoclopramide. If it is not responding to the metoclopramide, we can, and if it is a radiotherapy or chemotherapy induced, we can give steroids along with dexamethasone. And it is a metabolic cause is there, that is uremia or diabetic ketoacidosis, then we can give haloperidol as an antiemetics. And for the raised intracranial pressure, we can give steroids. Delayed gastric emptying, we can give metoclopramide as a prokinetic agent. And if a gastric irritation is the reason, we can stop that irritants and we can add proton pump inhibitor. So the another important topic, that is opioid induced vomiting. How this opioid can result in vomiting. So there are different mechanisms. That is mainly the area involved is chemoreceptor trigger zone. It increases the vestibular activity and stasis, and that will result in constipation. So the drug of choice is for opioid-induced vomiting is metoclopramide. If it is not responding to the metoclopramide, we can give haloperidol. And usually we have to we can start this antiemetics as initially to prevent the symptoms. So we can, if we are starting a opioid, along with that, we have to give that metoclopramide as 10 milligram as TDS and SOS dose for initial 3 days. After that, advised to take it as an SOS doses. So from the summary or the nutshell, mainly the cause for the nausea and vomiting, it is a multifactorial. And if any correctable cause is there, you have to correct it. And first we can try some non-pharmacological measures or dietary modifications. If it fails, we can proceed with the management. And you have to identify the pathway which is involved in such vomiting. What are the different receptors which are involved in that pathway, and what are the antagonists, potent antagonists against that receptors which is identified, and what is the route of administrations. And the most of the time, this 1/3 of the patients may need combinations of antiemetics. And we can consider steroids to reduce the peritumoral edema. So usually we are routinely prescribing Emised or ondansetron for all types of vomiting. So after this, you have to give an appropriate antagonist or medicines which are for the particular type of vomiting, which path, according to which pathway is involved in it. And our routinely or usual antiemetic, that is Emised or ondansetron, it is very expensive. So after this session, you have to uh, write the appropriate antagonist for the pathways according to the receptors which are involved in each pathway. So this is regarding nausea and vomiting. If you have any doubts, you can ask now. So this part is little bit difficult because pathways, receptors, antagonists, everything is little bit confusing. So after this class, you have to go through the slides and you have to study these receptors and pathway thoroughly, and then it will be easy. You can ask the questions in the chat box, or you can unmute and ask.
The participants kindly ask your doubts. Can we move
If you
to the
have,
next part?
so yes, if you have no doubts, you can proceed to the next part. That
Okay.
is constipation and malignant bowel obstruction. So, is it visible?
Yes, ma'am.
Yes, okay. So, next moving to constipation. So, by the definition, or what is constipation means, it is difficult or painification, and it is associated with infrequent bowel evacuations and hard feces. That is not only as a uh, uh, layman, usually they are telling that if they, from their aspect, the constipation is not passing stools. It is by a medical definition, it is not like that. It is sometimes it is a difficult or painful defecations, and sometimes it is infrequent bowel evacuations. That is, patient has regular bowel habit, but it is not satisfied, and there is passing a hard feces. So these three conditions can tell us or that result in constipation. So usually it is a subjective feeling. That is how it is different from their normal habit. So first you have to ask the patient what is their normal habit. Sometimes the patient has a normal bowel habit once in 2 days or once in 3 days. This is their normal. Then this is not a constipation. So when it is different from their normal habit only, then we can say it as a constipation. So 45% of the palliative patients are constipated on admissions or on their first visits. So what are the symptoms? How usually they are presenting? That is feeling of incomplete evacuations, bloated feelings, nausea and vomiting, abdominal cramps or pain, symptoms of bowel obstructions, overflow diarrhea. Anybody knows what is overflow diarrhea or spurious diarrhea? Any idea? Anybody heard of? No idea. Okay. So, in the coming slides, we will tell in detail about what is overflow diarrhea or uh, spurious diarrhea. So, next is urinary retentions, and these are the different symptoms. So, why we are more worried about constipation? So, in advanced diseases, it can cause colic abdominal pain, anorexia, nausea, vomiting, urinary retentions, anxiety, and confusion and delirium in elderly patients. So, what are the different causes? So, first thing is pharmacological causes. So, first, you have to review the medicine chart of the patient. If 90% of the opioids can result in constipation, antidepressants, anticholinergic drugs, antiemetics, antacids, somatostatin analogs. So, these all medicines can result in constipations. Next is metabolic. So, metabolic means it is that is dehydration, hypercalcemia, hypokalemia, uremia conditions result in constipation. Next is dietary, that is poor appetite, low fluid and fiber intake. Environmental factors, that is hospitalization, inability of the patient to attend to the call, timing issues, privacy issues. So that is the environmental factors. Neurological factors, that is malignant bowel obstructions or malignant spinal cord compressions, sacral nerve infiltrations. Structural causes include pelvic tumors, radiotherapy-induced fibrosis, painful anorectal conditions, and intraluminal obstructions. Some other or miscellaneous causes include depression, weakness, immobility, inactivity, sedations, and extremities of ages. So, the 90% of the opioids can result in constipation. So, in our practices, usually we are routinely using morphine. So, how this morphine can result in constipation? So, first thing is by decreasing the propulsive intestinal activity and make additional time available for the water reabsorption, and it will inhibit the secretomotor neurons and less fluid enters into the gut, and it will reduces the sensation of rectal distension and fecal impactions. So, these are mechanism how this morphine can result in constipation. So how we can assess? So first you have to ask the patient what is the normal habit. What is the normal habit for the patient? What is the frequency? What is the amount of stool? That is, what is the consistency? Whether it blood stained or not? When was the last bowel movement? Is the patient is experiencing any abdominal discomfort or crampy or colic abdominal pain along with nausea and vomiting or excessive gas formation or rectal fullness? So these associated symptoms are also have to ask the patient. And does the patient is regularly taking any laxatives? What are the medications the patient is on to rule out the pharmacological causes? And ask the patient whether this constipation is a recent change or not, and ask in detail about the patient dietary habits. So these are the some common issues or common what send common questions or common things usually we are facing. That is, most of the time when we are asking about the bowel habits, the caregivers or the patient, they will tell that doctor or we are not or patient is not eaten enough at all. How he or she will pass motion? Is it correct? Is this question is correct? If the patient is not able, not eaten enough at all, then how he or she will pass motion? Or sometimes they will tell that I have diarrhea. Whether it could be true diarrhea or overflow diarrhea, you have to identify. So for the first part, first question, that is not enough, not eaten enough at all, he or she will pass motion. So that for that, you have to tell the caregiver or patient that our large bowel transit take 3 to 4 days, even in a normal people. So the stool contains shredded epithelium, and major bulk is the byproduct of the bacterial action. So even if the patient has not taken any food for or few days, he may need bowel care once in 2 to 3 days. That is, the major bulk product is the byproduct of the bacterial action and also the shredded epithelium. Not at all, not with the yellow. If normally we are thinking that the food is the major bulk of the stool. It is not like that. It is the byproduct of the bacterial action and also the shredded epithelium. So if the patient is not take an adequate food for few days, or uh, not an adequate quantity, but the patient may need a proper bowel habit in once in 2 to 3 days. That is very important. So next is Bristol stool chart. How we can assess the consistency of the stool. So this is from type 1 to 7. So type 1 and 2 indicates the patient has constipation. 3 and 4 indicates this is a normally functioning bowel, and 5 to 7 indicates patient has diarrhea. So 1, it is a separate hard lumps like nuts. 2 is sausage shaped, but it is lumpy. 3 is like a sausage, but it is with the cracks on its surfaces. 4 is like a sausage or snake and smooth and soft. 5 is soft blobs with clear cut edges. 6 is fluffy pieces, ragged edges, and with a mushy stools. And the 7 is watery, no solid contents. It is entirely liquid. That is watery diarrhea. This is how we can assess the consistency with Bristol stool chart. So how we can manage? So this is one of the main thing, that is, if any correctable cause is there, you have to correct it. And judicious use of laxatives is very important. Improve the general conditions, symptom control, encourage the activity of the patient, and include fiber diet in the mix. So what are the non-pharmacological measures? So, and access and go to the toilet is very important. Timing and privacy issues is very important. And the position, that is, most of the time we are comfortable with the squatting position. So in the bedbound patients, they are not able to do the squatting positions. That time we can try some lithotomy like positions, that is patient to give a gentle blowing. And most of the time this is not 100% method, but we can try these methods and encourage the normal balanced diet with plenty of water. So how we can manage? So first, we if you are suspecting a constipation, and first you have to do the rectal examination. That is, per rectal examination is very important. Proper use of the right laxatives, and you can provide suppositories or enemas, and do not give subwater enema. And we can also do digital rectal evacuation, that is mainly for the hard impacted stools in the rectum. So how we can do a parectal examination. So, after education of lignocaine jellies, we can do a parectal examination. So, what are the different findings usually we are getting while doing a parectal examinations? The first is, if the rectum is empty and collapses. So, if the rectum is empty and collapses, that indicates it is a normally functioning bowel. If the rectum is empty but it is dilated, then it is indicates feces will be high up in the bowel. There is constipation is there. And sometimes that is feel like a balloony, that is ballooned rectum. That is, it is grossly dilated. So that indicates it is a gross constipation. Sometimes you can feel the feces in the rectum. So that time you have to determine the consistency, whether it could be soft loaded or hard or impacted stools. That is depending upon the consistency you have to manage. If it is a soft loaded, we can give suppositories. Impacted hard stools, we can first do the digital rectal examinations, and then we can give enemas. If you can feel any or irregular, hard, immobile mass, refer the patient to the higher centers for further evaluation. That is also very important. So for the soft tools, we can give bisaccharide suppositories. For the hard, we can give glycerin suppositories or empty rectum oral stimulants along with the high enemas. Manual evacuation with the lubricants mainly for the hard impacted stools. So How we can do a manual evacuations. So for the manual evacuations, proper explanation about the procedure to the patient and caregivers and get an informed consent. Sufficient application of the lubrications, preferably with local anesthetic jelly like lignocaine, allowing enough time for the local anesthetic to act. Gentle and slowly doing the procedure with careful watching of the patient reaction and acceptance. At the same time, you have to keep talking with the patient. That will also decreases the anxiety and distress. So there are some few recommendations. That is, first is for the paraplegic patients need regular stimulants and stool softness. The patient may need initial evacuations. Patients with colostomies are treated in the same manner. After obstruction is excluded, bisacodyl suppositories can be used, but it is less well absorbed and oral tablets need to be added. That is also very important. These are the few recommendations. So this is very important. The hand that charts morphine should chart the laxatives. So judicious use of laxatives along with opioids is very important. So these are the different types of laxatives. First is bulk forming, that is methyl cellulose, psyllium. Next is lubricating, that is mineral oil, osmotic, lactulose, magnesium hydroxide, that is milk of magnesia, and polyethylene glycol. Next is stimulant laxative, that is bisacodyl or dulcolax and senna. Next is stool softness like docoside sodium. So these are the different types. So this is a little bit in detail about each types. That is first is bulk forming. So in bulk forming, this it increases the fecal mass, it stimulates the peristalsis, and stool become more bulkier and softer. And it is unsuitable for elderly or debilitated patient as they need to drink extra fluids. That's why it is very cautious while using an elderly or debilitated patients, and it is not normally used in palliative care patients. So, because most of our palliative care patients are not able to take a plenty of or enough fluids. And next is osmotic or debilation. Osmotic laxatives are the lactulose. It is a non-absorbable sugars exert on osmotic influence causing water retention in the lumen. So it can result in dehydrations and it can cause cramping, pain and nausea. So fecal softness, that is liquid paraffin, it is not used alone as a laxative. It is better to continue with a stimulant laxative. Stimulant laxatives is bisacodyl. So it has a direct action on the meningeal plexus and submucosal plexus. And he has both motor and secretory action. It should be avoided in complete obstruction. So this is one of the model prescriptions, that is for the step 1, that is bisacodyl as a 10 milligram as an HS dose. Usually the tablet is available as 5 milligrams. So advise the patient to take as a 2 tablet at the bedtime along with or without softness. If the patient is not responding to a single dose, we can increase it to as a twice a day. That is 10 milligram in the morning and 10 milligram in the night along without the softness. If it is failed to get a proper bowel habit with this BD dose, we can increase as a thrice a day. That is morning, noon, and night, along with or without measures. If it fails, we can do a rectal measures, that is manual removal, suppositories, or low or high up enemas. So what is spurious or overflow diarrhea? This is very important because that is patient or caregivers usually they are telling that it is only diarrhea. So you have to find out whether it could be true diarrhea or overflow diarrhea, because the management of true diarrhea and over diarrhea is entirely opposite. So you should when patient is suspecting a true diarrhea, you have to give the medicines to stop the diarrhea. That is mainly this probiotics, or if any infection is there, there's antibiotics. So that is the medicines. Usually, if we are thinking that it is an overflow or spurious diarrhea, then you have to manage the constipation. This diarrhea is mainly due to the constipation. So if the patient has frequent watery stools, small in quantity after a period of constipation, that is very, very important. If the patient has a history of constipation, followed by this frequent watery stools, then you have to think that this is most probably due to spurious or overflow diarrhea. So ask how many days back patient has a satisfactory bowel habit. So the mechanism is it's constipation for a longer duration, and the longer the stay of stools in the gut will increase the reabsorption of water, and it will become more harder and harder the stool, and patient may presenting you with a severe constipation. So in these cases, the guts in the bacteria it will putrefy the newly formed stools, and the stool become more watery, and it comes out through the sides of the that bowel mucosa and the stool, and it will comes throughout the orifices. So that's why this patient has presenting as an frequent watery stools. So this is mainly due to the constipation. So here you have to treat the constipations with enema, then this diarrhea will be relieved. So from the conclusion, so constipation is a symptom, it is not a disease. So no laxatives work if you do not give enough or you do not give it at all. And will generally need, patient may need softness along with stimulants. So that is very important. So if you have any doubts regarding this constipation, you can ask now. This is also a very important topic, because this is one of the most common symptom usually we are seeing in palliative care patients. So ask the patients regarding this constipation or bowel habit is very, very important, because they are not most of the time they are not uh, freely express these bowel and bladder habits as like pains. So that your duty is to ask the bowel and bladder habit is very important to rule out the constipation and retentions of urine or something. If you have any doubts, you can ask. No doubts? Then we can proceed with malignant bowel obstruction. So, by the definition, it is any process which preventing the movement of bowel contents distally or forward, then it is a obstruction. So, mechanical malignant bowel obstruction is sometimes it could be due to ineffective motility of the bowel. That is something non-mechanical or not some neurological problems. And sometimes it is a structural cause, that is occlusion of the lumen of the bowel. So these are the different mechanisms of malignant bowel obstruction. So malignant bowel obstruction is a common complication of various advanced malignancies like cancer, pancreas cancer, colon malignancies, rectal malignancies, and ovarian malignancies. So malignancy is the most common cause of obstructions. uh, Sometimes it could be the depending upon the extent of obstructions. Sometimes it is a partial obstruction and complete level obstruction. Sometimes it is a single level or multiple level. So etiology is depending on the mechanical or functional. So this is an extrinsic. Extrinsic means something, some tumor growth or some masses which will uh, obstruct or cause compress or give pressure to the bowel from outside. That is an extrinsic. That is tumor growth outside. That is sometimes it's ovarian malignancies or pancreatic malignancies or uh, some other intra-abdominal malignancies or metastasis will give pressure or cause obstruction from outside, and sometimes post-radiational fibrosis or malignant adhesions. Some intramural. Intramural means that tumor growth is within the muscle wall. This picture shows that is tumor growth is within the muscle wall. Next is growth of the tumor within the lumen. That is inside the lumen, the tumor will occlude at the normal movement of the bowel. So pathophysiology, that is, there is luminal occlusion can happen that will result in reduced propulsion of the contents, and that result in accumulation of the contents. When something accumulated in the bowel, it will cause bowel distension, and this distension will increases the intraluminal pressure and that will stimulate the secretions. That is the mechanism. So what are the different sites of obstructions? That is, first is esophageal, and second thing is gastric outlet obstructions, and third thing is gastric outlet obstructions. Sites of obstruction. So, how we can identify the level of obstruction from the clinical history? That is, the level of obstruction determines the pattern of symptoms. So, if you are thinking that the patient has symptoms of high level obstructions, the vomiting develops early. So, that is the first symptom is the vomiting, and the vomiters is large volume vomiters. The quantity of vomiters is very large, and that is maybe gastric outlet obstructions or GI malignancies or duodenal malignancy. So this is in the higher level obstructions. If we are suspecting a large bowel obstruction, so in the low level, lower level obstructions, that is the first symptom is most of the time abdominal distension, abdominal pain. So the vomiting is the last or late symptom, and the content most of the time is feces. So that is a very terrible and distressing symptom. And the patient is, if you are suspecting there is a complete obstruction, the patient is not passing flaters, no feces, and sometimes they will presenting you with a spurious diarrhea. So what are the common symptoms? That is continuous nausea, vomiting, constipation, not passing flaters, abdominal distension is there, spurious diarrhea is there, vomit with the fecal content, and colicky abdominal pain. So, for the investigations, first we can do an X-ray of abdomen, that is erect X-ray of abdomen, that is to identify the level of obstructions. And to know the cause of obstructions, we have to do the CT. So this is the image, that is erect abdominal X-ray with multiple airflow levels. This each arrow indicating that is a multiple airflow level that indicates the patient has obstruction. So this is also features of obstruction. So how we can manage? So for the intestinal obstruction management, if you are thinking, if you are suspecting a partial obstructions, the aim of the treatment is to reduce the bowel wall edema and stimulate the gut motility. That is, partial obstruction means this is the lumen or gut wall, something partially applied. There is some potential space is there for the movement of the content. So if you are giving, and this there is uh, some peritumoral edema around this tumors. So if you are giving a steroid, this peritumoral edema will reduces and get more potential space to for the adequate movement of the bowel. So that is the main thing. And next is to stimulate the gut motility. That is, metoclopramide has a prokinetic action. So if you are giving this metoclopramide, it will induce the peristalsis and relieve this partial obstruction, and will relieve. That is mainly for the partial obstruction. But if you're thinking that there is a complete obstruction is there, that is the bowel sounds are absent, not passing flaters, motion, abdominal distension is there. So that time you have the main aim is to reduce the intestinal secretions and treat the nausea and vomiting. So to reduce the intestinal secretions, we can give some uh, but that is hyoscine butyl bromide, that is to decrease the secretions. Otherwise we can give octreotide. So for the initial management, the resting the gut for some days if possible, and sips of fluid can advise hydrate the patient with IV or subcutaneous with 10 to 20 ml per kilogram per 24 hours, and correct the electrolyte imbalance if present. And we can advise a nasogastric tube mainly for the decompression of the stomach. That is, if the patient has large volume vomiters more than 3 times a day, or the volume content is also very, for the decompression purpose, we can advise Ryle's tube. It is not for a feeding purpose, it is mainly for the decompression. So for the treatment, we can pharmacologically, we can give corticosteroids, analgesics, antiemetics, anti-secretory medicines, and stomatostatin analogs. So introduce the early treatment will reduces the symptoms and improve the quality of the patient. So we can start steroids, that is dexamethasone, that is 60 milligram per day as an IV. It's a long-acting steroid to be given before 3 p.m. as a late administration will interfere the sleep. So given for 5 days and slowly taper it down and stop. If vomiting subsides, continue the oral steroids. Steroid act by reducing the peritoneal edema, monitor the patient's blood sugar levels also, and given along with injection ranitidine to reduces the secretions. So, what are the analgesics? That is, the patient has two type of vomiting pains. That is, abdominal colic abdominal pain and persistent nociceptive pain. So, for the colic abdominal pain, we can give that is mainly due to the peristaltic waves against the obstructions. And for the persistent nociceptive pain, pain is due to the nerve infiltration. For that, we can advise morphine. For the colic pain, we can give antispasmodics. So hyoscine butabromide is mainly we are giving for the complete obstructions. That is to reduces the secretions. Do not give prokinetic. If you're suspecting a complete obstruction, you do not give a prokinetic like metoclopramide. That is, it will result in perforations. And sometimes we are confused whether it could be a partial or complete obstruction, and we are just started this metoclopramide. But after starting this metoclopramide, if the patient has increased colic abdominal pain, then you have to think that there is a possibility of complete obstruction. Suddenly, you have to stop this metoclopramide. If only partial obstruction, passing flatus, having nausea and vomiting, and give metoclopramide. So, antiemetics, metoclopramide can, for the non-colicky pain, 10 milligram as a 8th hourly, maximum 120 milligram. Gradually increase the dose day by day. So, haloperidol for complete bowel obstruction, as an antiemetic, we can give haloperidol. And emisate, that is ondansetron, also used as an antiemetic. Bowel distension causes releases of the serotonin 5-HT receptor antagonist will help. So that is somatostatin analogs, that is 100 to 600 micrograms per day. The example is octreotide. It will reduces the secretions and slow down the motility. But it is not routinely using because it is very expensive. So histamine 2 antagonist and proton pump inhibitors. That is, it act on the gastric parietal cells or proton pump inhibitors, and it will reduces the gastric secretions. So from the nutshell, if you are thinking there is a evidence of partial obstructions, that is dexamethasone, that is steroid is to reduces the peritoneal edema, and metoclopramide to induces the bowel movement or increases the bowel motility, and also we can give it as an antiemetic for the partial obstructions. And if you are suspecting a complete obstruction, this hyoscine butabromide we can give, and as an antiemetic we can give haloperidol. So this is the drug of choice. So if the patient needs some palliative surgical correction, if with the best outcome, we can suggest resections, stoma formation, that is colostomy or ileostomy, and stentings. And we can consider some PEG tube insertions for the feeding if we are for the gastric outlet obstructions. So that's all. So this is regarding the malignant bowel obstruction. So this is also very important. So you have to identify whether it is a partial or partial or complete bowel obstruction, because the management is a little bit different, and how we can investigate if the outcome is, if a patient prognosis is good, we can investigate it. Otherwise, we are mainly focusing with the symptomatic management, and that from that we can improve the quality of life of the patient. So if you have any doubts regarding nausea and vomiting, constipation, or this malignant bowel obstruction, you can ask now.
Dear participants, kindly ask your doubts. Ma'am, there is one question. Can you please tell
Yes.
the dosage for obstruction again?
Okay. Dosage of obstruction means that is for the partial obstructions, we can give what steroids, that is dexamethasone, that is to reduce the peritoneal edema. So for the dexamethasone, usually we are advising as a high dose, that is 60 milligram as a single dose for the initial 5 days. So slowly taper it down and stop. That is usually we are prescribing as a 60 milligram OD dose for 5 days, followed by 8 milligram OD for 5 days, then 4 milligram OD for 4 days, and 2 milligram OD for 3 days. So slowly taper it down. And as a metoclopramide, usually 10 milligram as a TDS dose, or we can as a fourth hourly to sixth hourly dose as a bolus doses, or we can give it as a continuous infusion, subcutaneous infusions. That is mainly for the partial obstructions. If we're suspecting an complete obstruction, we can give hyoscine butabromide, that is 20 to 80 milligram as a TDS dose, or continuous infusions we can give. And we can consider as an antiemetic, that is haloperidol. That is haloperidol. Usually we are giving 1.5 milligram to 2. For the vomiting, we can start this from 0.75 milligram.
So they're asking like haloperidol and isoxin. Have you covered that point, ma'am?
I already covered. That is haloperidol is 0.75 to 1.5 to 3. Hyoscine is 20 to 80. Usually the initial dose we can give 20 milligram or 40.
Okay.
Continuous infusions also we can start. That is 40 milligram or 80 milligram over 24 hours, continuous subcutaneous infusions.
Okay. Thank you, ma'am. Is there any other doubts? Miss Radhi R said thank you, ma'am. She asked that
Okay.
question. So, any other question? Doubts or feedbacks? Uh, okay. I think there is no more questions. So we can wind up for today, ma'am. Thank
Yes.
you. Thank you for an insightful session. And okay, they are saying it was a good session, ma'am.
Okay.
Okay, so thank you, ma'am. Thank you for your insightful session, and you can leave now, ma'am.
Okay. Thank you all.
Thank you, ma'am.